everybody. I'm Esther Khatibi. Yes, it's a difficult last name. People always ask me where it's from. It's Persian, and I say it's like cat and TV. So just remember there's a cat on the TV, except for it's a TV. But I'm going to talk to you all about doing OB services within your direct primary care, and a little bit about how I got to this and my experience in direct primary care. So I'm going to go over an introduction, some objectives and highlights, challenges for what we went through with my direct primary care, and then conclusions. And if you would like to contact me afterwards, everyone is welcome to. So an introduction. So we know that within OB care, there are less and less family physicians who are doing it. We've seen morbidity and mortality rates go up in the U.S. It's been in the headlines quite a bit. And we know that everybody is saying, how do we answer this? How do we fix this in our model of care? And a lot of people are going towards access to care. But I would like to argue with direct primary care, it's not just the access, it's the quality of care that is needed as well for pregnant women. So I do think that we have the skills that are vital to answer this question by offering it within direct primary care. So a little bit about me. I did a fellowship in surgical obstetrics and women's health. I went on to be a obstetrics fellowship director with the residency program. I did that for 5 years. I trained other physicians. I'm still currently in the same community as the residency program. And I opened my direct primary care in 2020. With that, when I opened, I did offer OB services with it from the very beginning. And yes, I opened right after COVID hit. So that wasn't planned, but I had already given my notice to my job, and yeah, I opened in July of 2020. So a few of our objectives: I want to encourage those of you that enjoy doing OB to consider finding happiness in a model like direct primary care and do that. Or if you know somebody who does OB and you want to tell them about me, that would be great too. And then some similarities. Just because I do OB doesn't make it any different, because it's still direct primary care. I still do primary care. So there's a lot of things that I've gained from that is practical as far as just the direct primary care. So, and then provide practical advice while guiding you to think outside the norm. So most of the things that I have obtained within my direct primary care, I want to say it was an uncomfortable feeling. So I just want to encourage you, yes, if if you're not that kind of person that wants to take risks, find somebody who is to partner with, or just challenge yourself to jump, pretty much. So the highlights of doing OB within direct primary care is that it gives you a better relationship with your patients. You have more time for them, same as just direct primary care. You do have the option to take care of baby many times after, so you're gaining patients that way, and mom after the delivery. So, and then you have dedicated time to educate your patients, which you may not have in the other world or the other systems. So once I decided I was going to offer OB, I came up with all these ideas. How was I going to do it? Put all these ideas on paper, and then the next part was, okay, so now I've got all these great ideas. How am I going to make it work? So some of it was, doing some research, checking who else has done it. So anybody else who did OB, I contacted and asked them to share with me, like, okay, how did you do your pricing? What goals did you make? How many patients did you decide to take? All of those. And then, either asking them, hey, would you mind meeting with me again in a year, and kind of addressing these things. So And then this is kind of, grab a sip of water, sorry. Our main slide here, so, and this goes for any kind of specialty care or any other kind of service that you might want to offer, but you need to think about your pricing for it. For us, we just increased the monthly fee. We did require that patients sign a contract with us. We didn't have a lawyer or anything. We weren't going to hold them to it. I frequently told them that because I felt bad. I'm like, if you decide this isn't working for you, that's fine. But for OB, it is a little bit different because you want to be committed to that patient through their pregnancy, the delivery, and postpartum. One thing that we could not control was hospital pricing. With that, I tried to meet with the CEO of the hospital to get transparent pricing for our patients. Nobody wanted to talk to me. Nobody would give me the time of day. And then I happened to be in the doctor's lounge and happened to run into the president. And he was like, oh, I don't think I've met you. And I was like, no, I haven't met you either. And he's like, oh, I'm the president for I was like, oh, okay, great. And he's like, if there's anything I can ever do for you, just let me know. And I was like, okay, great. And I was like turning around and I was like, this is your chance, say something. I could feel my heart like beating so fast. And I'm like, he's walking away. And I was like, yes, actually, there is something. And he's like, oh yeah, so what's that? And I was like, I do OB and I have this model of care, and I really want to be able to tell my patients what it's going to cost, just a rough estimate. If they have a vaginal delivery versus if they have a C-section, what would the hospital charge them? And I said, and he's like, oh yeah, you can talk to this office. And I said, yeah, I have, and nobody ever gets back to me. And he was like, oh, okay. And then he's like, I'll get back to you, and here's my card. And he did. So like 24 hours later, he had emailed me with somebody else like, hey, please give this doctor the pricing for these. And so that was it. That was the golden opportunity, just being in the doctor's lounge. But yes, that's what I was saying about like risk or feeling uncomfortable. Like, yes, maybe you're not that person that just goes around and talks to everybody, but when the opportunity comes, take it. So yes, that's how we got our pricing. Then with that, I offer, in our contract, I list that to the patients, like, your monthly membership covers this amount. This is for your prenatal care, your postnatal care, and your delivery. And then these are what's expected for the hospital. Now, this may not be exactly, because if you stay 2 days in the hospital versus 3 or 1, it may change, but at least then they have a general idea for that. So other important things, so for doing OB, the call schedule is usually what makes it more difficult for anybody. With me, starting in 2020, it was COVID, and I didn't have anybody else to use. They told me I could not use the residency program as my backup because we had OB hospitalists, and they were the backup for the family medicine physicians. So if I used the family medicine, it would be like using the OB hospitalist. For whatever reason, they backed me into a corner and said I could not be on the call schedule with them, and they also told me I could not be on the call schedule with the private physicians because I wasn't an OB-GYN. So I was kind of stuck out on my own. So for 3 years, 24/7, I did call. And yes, that probably led to a little bit of burnout with it, but I would just take less patients when I felt like I was getting overworked with it. So that was one way for me to manage it. And I guess there are better ways trying to find somebody. I'm in a smaller town in Corpus Christi, Texas, which is way south Texas. And it wasn't that easy to find a partner to do that with me. So yes, and I will kind of move on at the end to tell you what we're doing now for some of these things. But I do encourage you to try and think about these as far as call schedule, how you're gonna make it work. The good thing was with COVID, our family wasn't really traveling or going anywhere either. We were kind of stuck anyway, so being on call wasn't that terrible. But yes. And then expectations, so our meet and greets, our after-hour calls. So if you do OB, you're gonna get more calls. You just are. And knowing that and preparing your patients, I think even within direct primary care, when people sign up, I always tell them, yes, I'm married, I have kids as well, so that they see you as a real person. That, I said, if you call in the middle of the night, you may hear a child, or you may, realize that you're waking up other people in the house as well. And that's not to discourage them from calling, it's just to discourage them from calling if it isn't urgent. So other expectations, so we do like a folder or something that we give to all of our new patients. We also give them prenatal vitamins. In the beginning, we had acquired a bunch of stuff from another office, and we had tons of diapers. So we would give out diapers and baby blankets when the baby was born. And that helped. Surprisingly, people love free stuff, and I think the baby blanket made them realize that we just weren't a regular office. So I would also typically ask them, what's your theme for your nursery, or those kinds of things. So if they had a jungle theme, I would try and get a jungle blanket. And yes, I went out and bought them. And I actually really loved it, so it wasn't a big deal. As far as referrals with doing OB, so I share an office with a neonatologist, which was very helpful. They actually are hospitalists, so they're never in our office, and I ended up renting from them, which turned out to be a great deal, because they really don't care what I do in the office. They're never there, except for they have one room with weight equipment where he comes and works out at night when he's on call. So, and they had some furniture and other things that they let us use. And when I initially started, we used one office as an exam room, and then we had one work area room, and he had one office, and he had his weight room. And little by little, there was two larger exam rooms that nobody was using, and then there was a small closet, and there was another little area for a break area. But little by little, when I started, I was oh yeah, we just need the one exam room, and I was thinking okay, I'm just gonna need this and I'll carry on. And little by little, I was oh, can we use that space? Okay, can we use that space? Can we use that space? And then he was if you want, I can move out of my office and I'll just put my desk in the weight room. And I was okay, yeah. And then now, we have a girl who comes in and helps with marketing, and her desk is actually in his weight room too. And so I was we pretty much squeezed him out of this entire office, but he's so nice. And I just always tell her, if he comes to work out in the middle of the day, we just leave that area. So he seems happy and we seem happy. And then other people, as far as reaching out to community resources, so we have a pregnancy center. They refer a lot of patients to us. And then we also have a family planning clinic. So I used to work at the family planning clinic. I did their LEAPs, I did their colpos, and I worked for them for about 3 years. And so now I just stop by and say, hey, if you have any pregnant patients, because they don't do any OB, just send them over. So they will send them over to us. So I do a lot of women's health and the OB, which is helpful. As far as Medicaid and those kinds of things, so I opted out of Medicare and Medicaid, I want to say within 6 months of starting my DPC. I know a lot of other people say don't do that. My idea was, and maybe I was misinformed, was that you can't bill Medicaid if you're part of those together. Now I'm in Texas, so I know everywhere has different rules. So I was like, well, pretty much all OB qualifies for Medicaid if they're in that low income bracket. So I just opted out of all of it. And that was kind of crazy because when I was on the phone with them, they were like, oh no, they're completely separate. And you hear all kinds of things. I don't know that I could give you the exact answer or not, but I just decided, like, I don't want to deal with it. I'm just going to opt out. And for me, I was like, if I opt out, then I know that I'm 100% in. It's going to motivate me to improve my practice rather than trying to find different ways to moonlight or those kinds of things. But everyone is different, so I am opted out, but I am an ordering provider for Medicaid. So, and then whenever you do OB, you're going to have to decide what you are comfortable with as far as high risk or what. I'm very comfortable with high risk. I do C-sections. I like high risk. I think they need more care. I think we are the answer for those high risk patients. So the higher the risk, for me, the better. I just say bring it. I think it can be very time consuming though. And of course the liability is there. So when you do OB, yes, your malpractice is going to probably be double or triple, even in Texas, what your other colleagues in direct primary care are doing. So you do have to take that into consideration. But yes, I've done twins, diabetes. One thing that I didn't consider, and I know everyone tells you try to plan for the things that you're not thinking about, but of course you're not thinking about them, so how can you plan for them? I do not charge for the delivery in the hospital or any of the hospital rounding. And for the first 2.5 years, I never ran into an issue with that. And then about 2.5 years in, I had a patient come in and she was 23 weeks and she went into early labor and they were like, okay, we're gonna keep her here in the hospital until she delivers. And I was like, oh my goodness. Like, I don't have a backup. I don't have anybody else who will see them. So I'm gonna have to see her every day in the hospital. Like, I did not have that in my mind. So something to think about with that. She ended up delivering within a few days. And so I didn't have that long stay to deal with, but I was definitely like, oh my goodness, I'm gonna be in trouble. So, and then I think the other thing is, coordinating what do you have in your office or what do you need in your office to make it work. So there are some things with OB that you should have in your office, like a Doppler, whether or not you're gonna have an ultrasound or those kinds of things. I don't really like negotiating or business deals or those things, but I will have to say that a lot of what I've got in my office was because of it. So any physician that was closing, I would contact them. I happened to see an ultrasound machine in their office. He was actually moving from one office to another, and I was like, hey, until you open your other office, can we just keep it in our office till your office is ready and we'll pay you something for it? And he was like, okay, yeah. So a 1.5 years later, he came back for his ultrasound machine, and we had already bought a transvaginal probe for it. And so I ended up giving him that, but he never charged us for it. And he could have, but I think he was just nice. But a lot of times just seeing something and asking is a good way to get out there and get something for your patients and for yourself. So my direct primary care is called New Life Direct Primary Care. The good thing about owning a direct primary care is that you own it. You call all the shots. You may be able to sell it at some point. And then you can, do deductions and some things like that. Well, 2 years into my practice, I realized I'm not making a ton of money off of OB. And I thought, okay, maybe I should give it up. My husband was like, yeah, you're really like losing money on this. And so part of me was like, well, I spent all this time training to do this. Maybe it's a waste of talent and energy and expenses for all the training that I went to do it, and then to go and give it up. So I started thinking, and I talked to some other people, and what I ended up doing was creating a nonprofit for just OB patients. So we completely separated our OB patients from my direct primary care. We used the same model. We used a lot of the same things. But by making it a nonprofit, we were able to get grants and donations. So what we were offering when it was within the direct primary care, and it's confusing because they're both direct primary care, a model, but when it was a for-profit business, we were having patients pay $150 per month, and then when a lot of them would struggle with that, and still we weren't making money because I wasn't charging for the delivery or the hospital part of it. So when we made it to a nonprofit, with that we only charge $50 a month, and it's based on your trimester. So if they come in later in their trimester, we charge them more, and the hope is that we would get them in earlier because they're paying less per month if they come in earlier. So that way they will get their prenatal care and reduce the risk of maternal morbidity and mortality with that. So there's a lot of things that make a nonprofit very difficult. So you have to have your board of directors, you have to have, there's a lot of rules with it. But I kind of just jumped, and so that is where I am now with it. We're a year in to having it as a nonprofit. We are in the process of separating them from one office. The hospital offered us space that we could use to have as a clinic for our OB patients, and they've also offered to help with funding for an ultrasound machine for us. So. And then some things we can do as far as like fundraising, which makes that easier. So if you have something that you love to do, and maybe are not making a ton of money off of it, this might be a route that you might consider. So yes, just another turn in the path there that many of you could try, or at least talk to me about it, or if you know somebody who's interested. So in conclusion, decide what works for you. Happy to answer any questions that you might have with it. And I have a vision to create this model and allow other physicians who do primary care and OB take the same model where you own your own practice, and then you are a branch of the nonprofit, so that we would have everything structured for you. You would still run both of yours, but you would be able to do both, because I feel like a lot of family physicians who do OB struggle with the same things, the call schedule, the pricing, all the things. If we could set it up, if there was a group of people who were interested in this, who already had bought into direct primary care, I feel like it would bring a lot of change. So, and these are our websites, and I have my business cards, or if any of you want to contact me, all this stuff is on the website. So thank you.